frequently asked questions about chronic obstructive pulmonary disease. What is COPD? COPD is a lung disease characterized by chronic obstruction of lung airflow that interferes with normal breathing and is not fully reversible. How is COPD diagnosed? The characteristic symptoms of COPD are persistent and progressive exertional dyspnea, cough, sputum production, wheezing, and chest tightness that can vary from day to day. There should be a positive history of exposure to risk factors of tobacco smoke, smoke from home cooking and occupational dust. All patients who are suspected to have COPD based on symptoms must be evaluated by spirometry. A FEV1 over FVC ratio less than 0.7 and a change in FEV1 less than 200 meters L after bronchodilators treatment demonstrates expiratory airflow limitation. Such a result combined with the presence of characteristic symptoms and positive risk factor exposure is highly suggestive of COPD. How is the severity of COPD assessed? The GOLD guideline uses a combined COPD assessment approach to group patients according to symptoms and previous history of exacerbations. Symptoms are assessed using the Modified British Medical Research Council, MMRC, or COPD Assessment Test, CAT, scale. COPD patients should be classified into Group A, B, C and D using the combined COPD assessment framework. What else should the assessment include? Assessment of comorbidities should be performed for patients diagnosed with COPD. COPD often coexists with other diseases that may have a significant impact on prognosis. The presence of comorbidities should not alter COPD treatment, and comorbidities should be treated as if the patient did not have COPD. Is there a role for chest X-ray? Chest X-rays are not diagnostic of COPD but are valuable in assessing comorbidities and excluding conditions, such as lung cancer and pulmonary tuberculosis, symptoms of which are similar to that of COPD. What is the patient reports acute or progressive worsening of symptoms? The following possibilities will need to be considered. The patient is experiencing a COPD exacerbation. The COPD severity is worsening. There is a superimposed acute respiratory condition, for example pneumonia, pneumothorax, pulmonary tuberculosis, lung cancer. The comorbid conditions, for example ischemic heart disease and heart failure, are unstable. What is the role of smoking cessation? Smoking cessation is a vital intervention in COPD which will preserve lung function and improve survival. It is recommended for all patients with COPD. What are the goals of pharmacotherapy in COPD? The goals of pharmacotherapy in COPD are as follows. Relieve, reduce and abolish symptoms where possible. Increase exercise capacity. Reduce frequency and severity of acute exacerbations. Improve health-related quality of life. What are the principles of therapy? Treatment needs to be maintained long-term. Treatment needs to be tailored according to severity of airway obstruction and symptoms, as well as risk of exacerbations, with stepwise increase usually required. Attention should be given to the route of administration, especially via inhalational route. When treatment is given via inhalational route, choice of device will depend on availability, cost and patient's ability. Use of a spacer with metered dose inhaler devices may overcome coordination problems and improve drug delivery. What types of bronchodilators should be used? Short-acting bronchodilators are prescribed on an as-needed basis and should be the initial empirical treatment for the relief of breathlessness and exercise limitation. Patients with persistent breathlessness, GOLD Group B, should receive a LABA or a LAMA. Patients with persistent breathlessness should be escalated to a LABA/LAMA combination. Patients with minimal symptoms but frequent exacerbations, GOLD Group C, should receive a LAMA as first-line treatment. If further exacerbations occur, treatment should preferably be escalated to a LAMA/LABA combination, A LABA/ICS combination can also be used. Patients with persistent symptoms and frequent exacerbations, Gold Group D, should be started first on a LABA/LAMA combination. What are the considerations when starting steroid therapy? Addition of ICS to standard therapy should be considered for patients with moderate to severe COPD, Gold Group C and D, with frequent exacerbations. The expected benefit of reduction in exacerbations should be balanced against risk of pneumonia. Standalone ICS is not recommended for COPD patients. Combination of ICS and LABA in one inhaler should be considered for patients in whom both ICS and LABA are indicated. For patients with frequent exacerbations, more than 2 per year, and persistent breathlessness with FEV1 less than 50% of predicted, Gold Group C and D, the use of combination therapy, LABA, ICS or LABA/LAMA, is recommended. Long-term oral steroids are discouraged in view of unfavorable risk-benefit ratio. Is there a role for methylxanthines? Low-dose theophylline may be considered in patients with COPD where symptom control is still not achieved with existing inhaled bronchodilator therapy. However, careful monitoring for side effects and drug interactions is needed in view of its narrow therapeutic index. Is there a role for long-term macrolides? Long-term macrolide treatment, 6 to 12 months, may be considered in a select group of patients who have multiple exacerbations which are refractory to standard therapy. There is insufficient data to recommend routine use of macrolides in the treatment of COPD. Is there a role for mucolytics? Mucolytic drug therapy should be considered in patients with a chronic cough productive of sputum, and should be continued if there is symptomatic improvement. When is long-term oxygen therapy indicated? Long-term oxygen therapy is indicated in patients with severe COPD who are in chronic respiratory failure, blood oxygen saturation less than 88%. What are the surgical options? Lung volume reduction surgery is indicated in selected patients with upper lobe emphysema and poor exercise capacity after rehabilitation. Bulectomy may be beneficial in selected COPD patients with bully occupying more than 1/3 of the hemithorax. Bronchoscopic lung volume reduction treatment may have a role only in carefully selected COPD patients. What vaccinations should be offered to COPD patients? COPD patients should be offered annual vaccination with the seasonal inactivated influenza vaccine. Pneumococcal vaccination should be considered in COPD patients.
Audio Jungle. Audio Jungle.